So good evening, everyone. I hope you're well and thank you for joining us for this evening's session. My name's Ange. I'm one of the relationship managers at HCA Healthcare UK and I'll be chairing this session. So I'll go through a few housekeeping notes and introduce today's speakers. But first of all, HCA Healthcare UK, we're the private network of hospitals, which include the London Bridge, the Wellington, Princess Grace, Harley Street Clinic, Lister Hospital and the Portland. And we also have an Elstree outpatients which is part of the Wellington group. So if you've got any questions about the services at HCA UK hospitals, please do get in touch. I'll leave some information in the chat box. Now, I'm sure you're all aware of the huge wait times in the NHS hospitals. We've had many inquiries about private insurance and also self-pay pricing of diagnostics and procedures. So I'll share some links in the chat box as well. So just to remind you of the housekeeping rules, mics to be muted, videos switched off. However, this talk is for yourself. So please do type your questions in the chat box and we will read them out to the consultants at the end of their presentation. So I'm delighted to introduce, we have three speakers from the Wellington Hospital today. So we're going to start with the Dr. Bourget, who will be talking about the pathway of the pituitary patient, followed by Dr. Rahim on headaches, and the last speaker, but not least, Dr. Aditi Gai, who will talk about medical cannabis, and we'll do the questions after our third speaker. So I'm going to mute my mic and turn my video off, and over to you, Dr. Borge.
Thank you. So I'm hoping you can see my screen.
Yes, we can.
Yes, we can.
Thank you. So my name is Anouk Borg. I'm a neurosurgeon and my specialty is skull base and pituitary surgery. So today the talk is about pituitary surgery, but I wanted to give it from a perspective of a GP. For you to understand the journey that a patient goes through to undergo pituitary surgery. So the journey often starts with the GP. You may see patients who have incidental findings of a pituitary tumor, or they may come to you sometimes non-specific symptoms such as tiredness or lack of energy, low libido or cycle disturbance. You can also have patients with joint pains and pain in their jaw that might be related to a pituitary tumor. Non-specific visual disturbance. Sometimes they may have had eye checks which come back as normal, or rarely even increased thirst or polyuria. So all of those symptoms can be caused by any lesion in the sella. And although the most common abnormality is pituitary adenomas, we also see other lesions in the sella. So they can range from Rathke's cleft cyst, meningiomas, to more difficult conditions such as craniopharyngiomas. You can have METs in the sella or epidermoid cysts, and you can have inflammatory disorders of the stalk that can cause hypophysitis or IgG4 disease, just to mention a few. So if we focus on the more common pathology, which are pituitary adenomas, more recently in the WHO classification, they're referred to as PITNETs, so pituitary neuroendocrine tumors. And broadly speaking, they're divided into non-functioning and functioning adenomas. So your non-functioning tumors will present with mass effect, and the mass effect can be on the optic pathway, then hence leading to visual problems, or mass effect on the normal pituitary gland and therefore leading to hypopituitarism, or mass effect on the pituitary stalk, and that causes the prolactin to go up, and then you can have symptoms related to that. Functioning adenomas, the main types are prolactinomas, growth hormone secreting tumors that cause acromegaly, or ACTH secreting tumors that cause Cushing's disease. And these patients will present usually from symptoms related due to this hormonal excess. However, you can also have large functioning tumors, and they can present with mass effect and with visual disturbance as well. So the most common type are the non-functioning adenomas, and these tend to be from the gonadotroph lineage. And because they are not producing hormones, they can reach very large sizes without hardly causing any symptoms. It's amazing how much the optic chiasm can tolerate stretch before it leads to visual disturbance. So the commonest visual problem is visual field loss, but you'll find that color vision is usually the one that is affected first. And in the slides, these are both non-functioning adenomas, and it's just to show you how they can vary in consistency. So this one here on my right of the screen is hyperintense on T2, so it shows you that it's very fluid-filled, whereas this one is solid on T2. So it's hypointense, which implies that it's a solid tumor and therefore more difficult to remove. And both these slides are showing here the optic chiasm stretched on top of the tumor, and therefore both these patients presented with visual field disturbance, your classic bitemporal hemianopia. So going back now to functioning tumors, so we briefly go through acromegaly. So this is from an adenoma that is of the somatotroph lineage, so it secretes excess growth hormone. And as we know, this then causes the liver to secrete excess IGF-1, which is the hormone that leads to all the symptoms of acromegaly. So acromegaly affects the whole body and is associated with increased mortality. And it's diagnosed biochemically with an elevated IGF-1, which varies according to age and gender. So you need to look at your lab's normal range. But when you have a suspicion from a raised IGF-1, then you need to also examine growth hormone, and the endocrinologists then go on to do oral glucose suppression tests to diagnose acromegaly. So the symptoms of acromegaly are not always as obvious as is from this picture. Your classic patient with prognatism and large hands and increase in size of shoe size and ring size. Sometimes it can be much more subtle, and the Pituitary Foundation has reported that it can take up to 2 years or even longer for a patient to be diagnosed with acromegaly. And if untreated, there's a twofold increase in mortality, particularly cardiovascular disease. So prior to surgery, we tend to get an echocardiogram in patients with acromegaly. So the management, the endocrine guidelines say that surgery should be first line for acromegaly, but there are also other treatment options that we tend to use in tumors that invade the cavernous sinus, and therefore it's not possible through surgery to remove the whole tumor. And these medications, they tend to be somatostatin analogs, such as lanreotide, for example, which work very well in bringing IGF-1 levels down. Or more recently, a drug called pegvisomant, which is more of a receptor blocker, IGF-1 receptor blocker. There's also radiotherapy, which we tend to use for recurrent tumors that have recurred even after surgery, or in residual tumors after surgery where you cannot access, such as tumors in the cavernous sinus. And there is a role for gamma knife radiosurgery in certain small targets, but again, it tends not to be first-line treatment. And also important to mention that for long-term follow-up, patients with acromegaly should have regular colonoscopies because of the increased risk of bowel cancer, and echocardiograms, as I mentioned earlier. Then I'll briefly go through Cushing's disease. So this is due to hypercortisolemia, which is secondary to high ACTH levels. that are coming from the pituitary gland. So this is Cushing's disease, and it's to compare it to, you can have ectopic ACTH secretion, for example, from a lung tumor. And so Cushing's disease is from a corticotroph adenoma. And the problem with Cushing's is that you lose your diurnal secretion of cortisol. And so even if the cortisol levels are not very high, there's no variation during the day. And Cushing's is also associated with increased mortality and causes a lot of comorbidities if left untreated. So your typical Cushing's patient that's, you know, from medical school has your striae, your abdominal fat, and your atrophy, muscle atrophy, and it's also linked to diabetes and high blood pressure, poor wound healing, etc. And this is the day curve. This is a normal diurnal secretion in a normal patient without Cushing's. And this is why we, when we assess pituitary function, we tend to ask for a 9 a.m. cortisol, because that's the time when we wake up where cortisol is highest in the blood. And at night, your cortisol should be negligible. And in Cushing's patients, you lose this curve, and it's more of a straight line, and that forms part of the diagnostic tests. So these tests and these diagnoses are usually made by endocrinologists, where you can have various tests like a late night salivary cortisol, 24-hour urine free cortisol, or a suppression test using dexamethasone. And the guidelines say you need at least 2 screening tests to diagnose Cushing's. And this should then lead to a pituitary MRI. However, there is often not an obvious lesion on the MRI in Cushing's patients, and then an IPSS is required, so inferior petrosal sinus sampling, to measure ACTH levels in the peripheral blood, but also in the petrosal sinus that drains the pituitary gland. And then the third functioning tumor, which is also the commonest, are prolactinomas. These can be microprolactinomas, so tiny, such as in this picture here, or very large tumors. It's important to diagnose a prolactinoma prior to operating on someone, because prolactinomas are treated medically with dopamine agonists, and the commonest one we use these days is cabergoline. And the majority of tumors, although not all, are very sensitive to cabergoline. And so surgery is only reserved for those patients who cannot tolerate cabergoline, or in those tumors that rarely but do not respond to cabergoline. And then another brief mention, the Rathke's cleft cysts are not technically tumors, they're developmental cysts, but they can also increase in size to a degree that can also cause visual symptoms, and they may need surgery. So I mentioned this earlier, that one of the commonest presentations these days, due to the ease of getting MR scans, is incidentallomas. So patients have a scan to investigate headaches or tinnitus, or sometimes we've even had patients with neck pain. They have an MRI of their cervical spine, and just in the top slices, it catches the bottom of the sella, and an incidental tumor in the sella is found. So how would you manage a pituitary tumor which is incidentally found on a scan? So a patient comes to you, they've had their MRI for their headache, and there is a sellar lesion. So what do you do next? So the first thing to look at is on the scan itself or on the report is whether the tumor is in contact with the optic pathway. Is there chiasmal compression? Is it in contact with the optic nerves? And if so, then they should be referred for a visual field assessment. Ideally, they would have a full neuro-ophthalmological assessment, not just their visual fields by their optician. And the ophthalmologists also these days do an OCT, and they can measure for ganglion cell thickness. And even if there is no visual field defect, but the optic chiasm is stretched, you might find that the retinal layer is already quite thin. And in those cases, patients need to be referred to a neurosurgeon. The other thing to consider is the tumor affecting pituitary function? And to do this, you need to obtain a pituitary profile, including a 9 AM cortisol, including the IGF-1 levels, growth hormone, thyroid profile, and the prolactin. And then you need to decide, is this a functioning tumor? And if so, then the patient should have an endocrinological assessment for a diagnosis of acromegaly, or Cushing's, or prolactinomas we discussed, for them to have a workup. So surgery is used as the first-line treatment for acromegaly and Cushing's disease. It's also the first-line treatment for non-functioning tumors that are causing visual problems. And as I mentioned, for those prolactinomas that do not respond to treatment or are intolerant of cabergoline, and the standard approach nowadays is the endoscopic endonasal approach. So there are some surgeons who still use the microscopic approach, but the commonest now approach is using an endoscope, which can give you access to the whole of the skull base in the sagittal plane. And I, for example, tend to use the endoscopic approach even for meningiomas of the planum. But focusing on pituitary tumors, we are mainly following the yellow shaded area in this picture. So under the pituitary gland here is the sphenoid sinus, and therefore this is a transsphenoidal approach, which gives you a very direct route to pituitary tumors. So I'll go now to quickly share a video of an endoscopic approach. I like personally to use one nostril whenever possible. I think this helps reduce the nasal morbidity after surgery. And here, for example, this is an example of using the right nostril with the septum here and the turbinates on the side. I'll fast forward where we access then into the sphenoid sinus. Hope that the video plays with me. Okay, sorry, don't think it's going to work. Okay. Anyway, you get the point that this is done through the nose, and we reach the bottom of the sella and open the base of the tumor and gently help suck the tumor out without damaging surrounding structures, and paying extra attention not to breach the arachnoid, which is between the pituitary and the rest of the brain. So complications or risks of the operation are risks of bleeding from the nose, risk of epistaxis, or risk of a hematoma in the sellar bed. So we take precautions during the operation, not to precautions to hemostasis afterwards. But we always consent patients for the risk that there may be a risk to vision by doing the operation, even though the goal of the operation is to save vision. There is a risk by doing these operations of affecting the function of the normal pituitary gland. And so that's why we test the cortisol axis afterwards. And there's also a risk that even though the operation goes well, all the tumor is removed, there is a recurrence. And patients should ideally be followed up long term, because you can have recurrences even after 10 years or longer after surgery to adenomas. And so as an inpatient, we monitor patients for AVP deficiency, what used to be called DI, diabetes insipidus, and now has a new name. We do this by monitoring sodium levels. We monitor patients for a CSF leak, which is one of the risks of surgery. The problem with a CSF leak is it risks causing meningitis, and often during surgery, which I was not able to show you on the video, is we take some fat from the abdomen and use it as a fat graft to prevent CSF leaks. And so whilst an inpatient, we monitor that that graft site is healing well. Sometimes we use lumbar drains to drain CSF. This tends to be more common in large tumors. And we also test patients to see whether their cortisol axis is working. And different surgeons can do different practices, but my preference is always to discharge patients on hydrocortisone because that is the safest, and then to test their cortisol axis later as an outpatient. Normally, then the journey of a pituitary patient after surgery is that they reviewed again after a week, because sometimes hyponatremia, which is a common complication of transphemoidal surgery, can happen up to 7 to 10 days after surgery. We also tend to review the abdomen and remove the clips after 7 days and check again for any clear fluid coming out of the nose, which can be a sign of a CSF leak. Having said that, it's quite common to have nasal discharge after this operation, and so not every fluid coming out of the nose is CSF. Often, if you ask patients to lean forward and wait 30 seconds, if it's dripping very fast, then that may be CSF, and they should be referred back as an emergency. Then the endocrinologists, most commonly there, we ask them to see the patients after 6 weeks to check whether hydrocortisone is still required, and also to have a full pituitary profile. And we tend to ask for the first MRI after 3 months, and then if all is well, to move on to annual MRI scans and annual endocrine reviews. So the journey can be simple, with from the GP referring to an endocrinologist for an endocrine workup, who then refers on to neurosurgery, who then refers back to GP for long-term follow-up. You can have more protracted or complicated journeys that involve other specialists, but ultimately it's important for all the specialists to communicate and work together to make this journey more pleasant for the patient. So in conclusion, a pituitary disease can be difficult to diagnose. Symptoms can be vague and non-specific. Certain things that might trigger you to get an MRI are hypopituitarism on routine blood tests, or high prolactin levels, or visual symptoms. And postoperatively, to keep an eye on for CSF leak in the first few weeks after surgery. If your patient is on hydrocortisone long-term, to have steroid education and sick day rules, and to ensure that the MRI follow-up is in place. And a good source of information is the Pituitary Foundation. I also guide my patients to go and look at this resource, which is very good for all pituitary conditions. And that's it. Thank you so much for listening.
Thank you very much, Anik. Brilliant. Thank you, Anik. It's always hard to follow a surgeon because you all have all those pictures and those videos, but I'll try. I'm Bazir Rahim. I'm a consultant neurologist. I work at the Wellington, also practice at the Shard in London Bridge. And my NHS base is just south of the river at King's College Hospital, where I'm attending consultant on the tertiary neurosciences unit. So I see all the rare and wonderful things that we can see in neurology. And I also run a specialist headache service, and I'm chair of the local Integrated Medicines Optimization Committee Headache Working Group, and I also lecture at the university on headache. So there's a pattern emerging. and I am interested in headache. Why is that? Because I think it really matters. So if you look at the figures, approximately 1 in 20 consultations in the UK are for headaches. So 1 in 20 of the patients coming to see everyone who's in the audience today will, on average, have a headache. I feel a bit of a fraud talking about headaches to a group of general practitioners, because when you look at the figures, 97% of headache is actually managed in the community. So they never have to see someone like me. But it's a very big number. So in general neurology practices, 1 in 3 of the patients who are referred in suffer with headache. And for the last year, pre-pandemic, there were 108,711, so just shy of 110,000 hospital admissions for headache. So it's a huge thing. And we can see that in the real world as well, where it's either the second or third, depending on how you count, biggest cause of disability worldwide, particularly about in women of, in their younger years, their productive years. So it's a huge societal problem, and it can cause a lot of misery. So no talk about headaches is complete without talking about the red flags. So if you look on Google, or if you look in your neurology textbooks, there's lots of different acronyms. I think since I completed medical school, Snoop has gained a P and O. But I think it's quite a good system for trying to work out when you should be worried. Because when we see headache patients, it could all be primary or it could be secondary, and it tends to be secondary which you're worrying about the first time a patient comes to see you. So you want to make sure that there's no systemic problems. The patient's not feverish, the patient doesn't have a rash. They tend to be quite sort of self-evident problems, so we generally don't tend to miss those things. But it's also important just to look at the patient in context. They have HIV, which makes them more liable to brain abscesses and infections. Have they had a cancer before? So could this be a metastases causing the headache? Or, for example, are they pregnant, where the hormonal fluctuations mean that women are more liable to things like cerebral venous thrombosis? Examination is very helpful. So you want to make sure they don't have any neurological problems, and you want to especially look in the back of the eyes and make sure there's no papilledema indicating there's raised pressure. You want to also, what you generally want to feel happy is, there to be a pattern where they have headaches and they get better over time, because bad issues don't tend to take a break. They don't take holidays. So a headache that's due to something that's really worrying tends to be there from the onset and progressively worse. So those are the red flags, and nice to have them. And there's lots of resources where you can look them up if you want to learn more about them. But what I'm going to talk about really is the primary headaches. So secondary headaches are headaches that, reflect underlying problem. Primary headaches may not be so interesting or exciting. They won't make it onto Holby City, but that's where the bulk of my work is, and it's the bulk of the patients who are coming to see you in general practices. And the first sort of question you want to ask yourself when you see a patient with headache is to see if it's bland. Although the Sahara is beautiful in its own way, deserts can be beautiful, but is it featureless, or is it more like the Amazon? Is there lots going on, lots of other things in association? And because that will help you split the headache into the 2 big groups, which are the tension type headaches and the migraine headaches. My first tip with tension type headache is to try not to diagnose it. Really, because once you diagnose tension type headache, you paint yourself into a bit of a corner. It's not, it's a well-researched area, but there's not so many treatment avenues available in tension type headache. So where you can, you really don't want to miss the migraine headaches, because that opens up a whole different avenue and lots of different sorts of treatments that you can suggest, and which will help the patient get better. So really, tension headaches are bland. They're featureless. These are the patients who complain. It could be a band around the head. It doesn't have to be, but it does tend to be bilateral, pressing in on the sides. And the patient will say that whilst the headache's troublesome, and it's troublesome because they've come to see you, so it's had an effect, it won't get in the way of them undertaking the activities of daily living. It doesn't get worse when they have to run for a bus. It doesn't feel like their brain is being scrunched around in their head when they move around. There's no light sensitivity, there's no sound sensitivity really. although technically you can have one or the other, but you want a generally quite bland headache. And if you do find someone who has tension headache, you know, the number 4 comes up in a lot of the treatments for headache disorders. If it's less than 4, you concentrate on attack medicines. If it's more than 4, you start to think about preventatives. It's not fixed in stone. It's a good way of thinking about it. And for the attack side of things, in tension type headaches, you tend to, escalate up a ladder. You don't use the triptans, which we'll talk about in a bit, which are very often used in migraine. But you concentrate on paracetamol, then non-steroidals. And if the patient does have nausea, prochlorperazine can be a good call as well. If it's happening more frequently than 4 episodes in a month, and it's becoming an increasing problem for a patient, or if you notice that they're starting to have to take the paracetamol a bit too often, then you think about prophylaxis. And there's not very many licensed drugs in tension headache, and the commonest ones are the antidepressant class drugs, so either amitriptyline or nortriptyline, if the amitriptyline proves to be very sedative, or venlafaxine, and acupuncture if you have access to that. So the bigger cause of headache tends to be migraine. So migraine is the featureful side of headache. So there's lots and lots going on when patients come to speak to you about their headaches. Sometimes it can be quite difficult to tease out, where the pain is or what the pain is, because the patient's much more concerned about the nausea, the light sensitivity, the sound sensitivity, the motion sensitivity, and the brain fog. So that patients have lots of different ways of describing all of the symptom complex that is a migraine attack. But it's very featureful, and the patients are very good at conveying that it's not just the headache, it's not just that they have pain in the head, there's lots and lots going on. In headache, we're slightly like train spotters in headache medicine, in that we like to tick boxes to be sure of our diagnosis, and the organization that brings that together is the International Classification of Headache Disorders, which every few years brings out new guidelines, a new checklist for us to check. And on the right of your screen, you'll see what the checklist is for diagnosing migraine without aura or migraine with aura. But really, and this is validated in the States, there's the ID migraine system, where if a patient answers yes to 2 of the following 3 basic questions, you can be fairly sure that what you're dealing with is migraine headache. So has the headache limited the patient's activities for a day or more in the last 3 months? So if you remember from the tension headache slide, tension headache is annoying, but patients will say, I can power through it, get to work, I could give a presentation. Whereas migraine is not the same. You want it to be starting to have an impact on their ability to function. You want to ask if they're nauseated or sick, and whether light bothers them. Now, light being bothersome is a slightly difficult one, because this isn't someone who's like Count Dracula and can't go out in sunlight. You just want to find out if background ambient light is irritable to them. So, for example, do they start to avoid looking at screens? Do they want their partner to dim the lights? Do they want the curtains to be closed? And once 2 of those 3 questions positive, you can be fairly happy that you're probably treating a migraine, especially if it's a headache that is recurrent and between episodes there's no problems. So general and conservative measures are very important. So things that the patient can do rather than medicines that all come with side effects. So you want to always make sure that they're well hydrated. So drinking at least 2 liters of water per day, which is on the low side, actually, probably even more than that. Caffeine can be a double-edged sword. So when we didn't have access to very many medicines, a can of Coca-Cola would be quite often suggested as treatment of a migraine alongside some aspirin and paracetamol. But we know that regular use of caffeine in the migrainous brain is not a good idea. So if they can, to stop coffee entirely, otherwise to make a concerted effort to limit their caffeine intake. It's always worthwhile exploring triggers for patients. But human beings are very smart, so our patients are very intelligent. If there is a very clear-cut trigger, if every time they have a tangerine, they have a stonking headache, they can work that out pretty quickly. And I don't like when patients become very, you know, they become very neurotic around triggers, they keep these copious diaries. All the diaries are good, but copious diaries regarding triggers, and they start eliminating lots of things for them from their life. I think that's counterproductive generally. So you want to see if there are triggers, but you want it to be a general question. You want, and another good point to get across to patients is that whatever the patient's politics, their brain, the migrainous brain, is fairly conservative in that you want to they should try to have regular sleep. They should have regular small meals, and if they're going to exercise, that's absolutely fine. It's actually very good. Studies support that, but you don't want someone who, you know, goes from nothing to a marathon, or someone who, you know, sometimes wakes up at 4 in the morning and then has a lie until 10 a.m. because that's the source of provocative factor that's probably going to trigger a migraine in someone who already has a propensity towards them. So once you've diagnosed a migraine in your patient, what can you do? Well, the first step is very simple sorts of stuff. So simple analgesia, paracetamol. Patient would often say it doesn't touch the sides, but that doesn't mean that it won't work well in combination with other medicines. Next step up would be to introduce an antiemetic. I like prochlorperazine. Yeah. And very important thing that you can do is to stop or avoid prescribing them codeine-based medications, tramadol, because that's going to be very counterproductive in the long term. If we have time at the end, I'll talk about medication of each headache, but codeine, I would have completely avoid its use in a headache. So you've started the patient on paracetamol, ibuprofen, there's no response. The second line are triptan type drugs. I think now, because the world of headache is exploding in terms of the medicines available to us, we forget how important and how useful triptans can be, and what a game changer they were when they first became available to patients. So they can be excellent drugs for patients. They have side effects, and patients tend to be able to tolerate those side effects, especially if we tell them before it happens what the side effects are. For those of you who've never had a migraine, never taken a triptan, it can make your fingers tingle, it can make your tongue tingle, makes you catch your breath. That's just it starting to work, and that passes within 5 to 20 minutes, and it helps with the headache. There's lots and lots of different triptans that are available. The most standard one, and the one I generally go with first, is sumatriptan. And you can use that almost like a ranging shot. So if you give them the sumatriptan, you can work out if it's helpful to them. Does it help the headache? If it helps the headache, but, you know, it seems to wear off, or the headache doesn't get totally doesn't totally melt away, then you can decide to step up the triptan therapy by using an agent like rizatriptan. And finally, you can go for elatriptan, which is probably the strongest triptan that we have available to us. Whereas if the patient comes back and says the triptan, you know, was useful, but it was terrible, the side effects were terrible, or the headache started to creep back in over a few hours, you probably want a gentler triptan, and one that works over a slightly longer period of time. And you could go down the routes of naratriptan, almatriptan. So it's important to remember that the triptans aren't all alike, and that they're useful agents. They're not 100% effective even in patients who are triptan responsive. So if a patient takes one sumatriptan at 50 milligrams once and says it didn't work, it's always worth them trying again, you know, and going up to 100 milligrams the next time they try it before you rule it out, because if you do rule it out, the patient is missing out on their safety parachute for attacks. So prevention, again, the magic number is 4, but that's not cast in iron. So if someone has one migraine attack a month, but that migraine attack is terrible and it's costing them opportunities in life and it's causing lots of issues, they might want to go down the route of preventatives. Generally, we start considering preventatives if there are more than 4 headaches occurring in a month, or if it's having a significant impact on their quality of life, or if we see that their use of attack medicines is creeping up. Yeah. So from things that, you know, we can prescribe from general practice, you basically try to work out what's going to be best for the patient overall. So if there's someone who has trouble sleeping at night, or they're slightly on the thinner side in terms of their BMI, amitriptyline is a good initial choice. Propranolol, unless they're asthmatic, has very little, a few side effects, is relatively safe in pregnancy, so it's also a very good choice. Topiramate is over time going the way of valproate, so it's a teratogenic drug. Yeah, we have to absolutely avoid its use in women who become pregnant. So it's probably not an ideal choice, although it can work quite well in headache in some occasions, and males, it can be a good choice for them. And candesartan, which I personally like. It's much more used in the continent than we use it here in the UK, but it's got very good evidence behind it in migraine headache, and it has very few sorts of brain level side effects. The main side effect of candesartan is that patients report a slight degree of orthostatic hypertension if they stand up abruptly, which you can manage with just some lifestyle advice. It's also teratogenic, though. So if that doesn't work, what do we do? Well, we're very lucky in headache medicine that over the past few years, there's been a huge advance in more advanced treatments, basically mainly related to the discovery of something called calcitonin gene-related peptide, which goes up, you can find it in the serum of patients that having a migraine attack. Injecting it into someone who has migraines will trigger a migraine. And the next step was that we've developed newer agents, for example, the GPANTs, which are receptor antagonists, and the monoclonal antibodies targeted against CGRP, which both are really promising agents. These are obviously much more advanced treatments. There's lots of rules around them from NICE because they also tend to be quite expensive medications, and they have indications, qualifications, and stopping rules. So these are things that we would probably consider more in a headache service. And of course, there's Botox as well. So I'm just going to speed up before I run out of time. Another avenue that probably you don't encounter so much in the community is neuromodulation for migraine. The one neuromodulator which is a bit more accessible from the community is something like Kefali. It's not better than placebo in chronic migraine, but in episodic migraine, it shows some promise. Doesn't need a prescription. And I think the company that sell it returns some of the money if the patient finds no use and returns it to them. So it's something that patients who are very interested, you can suggest they have a read around. One really important area in headache medicine is medication overuse type headache. And I think this is something that can be really dealt with from the community. These drugs, the problem with them is they work very well at the start. So Solpadeine Plus, Migraleave, these drugs work well in occasional pain. Yeah, so someone who twists their ankle has a problem like that, takes the medicine for a very short period of time. It can be quite useful. In chronic conditions, like most of the headache disorders are, it becomes it's very counterproductive, and it sets the clock back on the patient getting better. I've put the figures in terms of how often they need to be using these drugs to meet International Classification of Headache Disorder guidance for diagnosing the condition on the left. But you can certainly see medication overuse headache developing with very infrequent, a few times a month uses of codeine. So my general suggestion to patients is to bin the codeine containing drugs. There was a lot of debates in the headache community about what the best way of treating this is. Is it to go cold turkey? Is it to phase the drug down? Look, if someone is on high doses of codeine or another opioid-like drug, it's going to be the best idea for them to slowly cut down. Going cold turkey is not going to help them. If it's something like paracetamol, I personally say to the patient for them to set a quit date, so that they're going to put on their calendar. After that, the offending drug, whether it's paracetamol, codeine, ibuprofen, whatever's causing it, they're just not going to use that any longer. And I use the period running up to the quit date to get them established on a good dose of a preventative. So if you think it's migraine, you want a good dose of a migraine preventative. Yeah. So I have a few cases at the end, but I think I'm just out of time, so we might skip that. And I will let Aditi have her full time to speak to you as well. Thank you very much for listening.
Okay, so I'm just going to try and figure out how to do this. Entire screen. Share. Can you see my slide?
That's perfect.
Yes.
Thank you so much, DT.
Excellent. Well, thank you so much, both of you, for wonderful talk. Both Anouk and Basu, very, very nice talks. Thank you so much. And thank you so much, all of you, for having me here today. So my name's Aditi Gai. I'm one of the consultants, anesthetists and pain specialists. I work at Elstree, HCA, and I also work at the Platinum Center and South Building. My NHS base is the Royal Free Trust. So initially, when I was asked to give this talk, I wasn't really entire. I thought maybe I'll talk about the pain clinic topics, you know, the usual neuropathic pains, neck pain, back pain. But then I thought, you know, why don't I talk to you about something which is fairly new, not so much, not being used as much as it potentially could. And I thought, let's just talk about medical cannabis this time. So just as a disclosure, I also work with a clinic called My Access Clinics. This is a private cannabis clinics, but I don't receive any remuneration or talks. This is just my experience on medical cannabis, which I want to share. So let's look at my journey. So I've been a pain specialist since 2010. So doing all the usual pain clinic stuff, and initially I was actually quite cynical about medical cannabis. And in fact, there was a referendum a long time ago, and I actually voted against medical cannabis because I wasn't entirely convinced. In 2019, I went to a conference, and there were some lectures because you see, cannabis had become legalized in Canada, and they'd been using it for a while, and they gave us some excellent talks on and some evidence and case reports and how things are working. It was really very convincing. And I simply got interested in it, but there was no way to get any experience in the UK. It's not available on the NHS. You can't just simply prescribe cannabis to somebody. So I joined this clinic, and I was one of the earlier prescribers for medical cannabis in the country. And at that time, we used to speak to people in Canada. We were in touch with them, and we would discuss cases via WhatsApp or email with them. But now I think our service has become more established, and it's been absolutely amazing, and I wanted to share that with you. So so cannabis has been around for a very long time. So 1840, Queen Victoria and her family used it. Fast forward to 1971. And at that time, when they introduced the Misuse of Drugs Act, they said cannabis has no known or limited medical value. This was 1971, not that long ago. However, a very important year in the history of medical cannabis was 1990, because that's when the endocannabinoid system was found. Prior to that, we were not aware that such a thing existed. After that, Sativex came into place, but 2018 is really the main year when things started to develop. So there were two very landmark cases, and I'll just go through them very quickly. So which actually led to legalization of cannabis in the UK. So Alfie was an 8-month-old baby. He started to have seizures because of a rare form of epilepsy, which they couldn't treat. Their parents created a huge media campaign. They collected lots of petitions, and they collected a lot of money for Alfie. They then traveled to Holland, and they got CBD oil, which controlled his seizures for 5 months, which was the longest stretch he'd ever had seizure-free. Subsequently, they ran out of money, and they came back, and nothing really changed. They couldn't bring the cannabis back. It wasn't legal here. Nothing could be done. This was the next landmark case, and this was the boy who actually helped the UK change the law on medical cannabis. So Billy used to have intractable seizures. His family had the money. They went to USA and Canada. And when they came back to the UK with this medicine, it got confiscated by the Home Office, and Billy's seizures returned. They were life-threatening. And then there was a lot of pressure from the lobbyists, from the family. There was a whole lot of media attention, and they said, well, the medicine is sitting there at the Home Office. And Sajid Javid then came in, and he said, okay, let's give it to this guy. And eventually, with all this pressure, the law changed. So now it is a Schedule 2 drug with restrictions, and I'll come to what it is in a minute. So this is what the law states now. This is the current law. So in 2018, it was changed from a Schedule 1 to Schedule 2. It can be prescribed in the UK today under MHRA guidance, and I'll explain that as well. And only people on the specialist register are able to prescribe it. So let's look at what the two drugs are. So Schedule 1 drugs are drugs which have a high abuse risk, but no medical value. So you're thinking of things like heroin, ecstasy, LSD, cocaine. So these are the higher abuse risk stuff, obviously, what we know of, street medicines. Schedule 2 drugs, however, they have high abuse risk. Yes, they are not easy drugs. There is a high abuse risk, but they also have safe and acceptable medicinal uses. And this is really, really important. Right person, right time, right prescription can be really, really helpful. But there is an abuse potential. So we're thinking morphine, diamorphine, oxycodone. We all use them. We are aware of the high abuse risk though. So, even though it's legalized, why aren't we able to use it? There's still a lot of barriers. It's an unlicensed medication. NICE, again, like a lot of other things, they came out and gave a statement and they said it doesn't meet the criteria for efficacy and cost effectiveness. So they said it's not good use of NHS money, which, okay, I get. British Pain Society in 2019 came out and gave a statement. They recognized that yes, it is useful, there is a place, but they said all the data on medical cannabis which we have is from outside the UK. So what we need more UK data, and then we'll have a think about it. So you see, because of this, the guidance in the UK is very restrictive. So that limits patient access. Not only from the authorities, but also from the doctors. People are not familiar with it. There's a stigma. It is an illegal drug, or at least it was. There's things about addiction potential. People are concerned. Normally, when a new drug comes in, it's the randomized control trials which happen, and then it comes in. But there is but unfortunately, with cannabis, there are way too many variables. It's much too complicated for RCTs. Pain in itself is a biopsychosocial phenomenon with too many variables. And also, it is not possible to have any patentable returns with cannabis. So it's really difficult to collect evidence on its use. So what the authorities have said, and this is accepted by NICE also, that for cannabis, what we are collecting is real world evidence. So that means all forms of clinical data outside the RCT settings. So think things like, patient registries, case series, patient reported outcomes, data from clinics, those sort of things, and we are collecting them now. Project T21 is the UK's largest medical cannabis registry. So what is happening in the UK is that there are over 1 million people who are using street cannabis for medicinal use. So what the Project T21 did was they said, okay, we will prescribe it for you legally and medically as per what is required. But in return, we are going to get you to do series of forms for us. I think it's every 3 months. So we are collecting data. And what we are hoping in the future, the data from the Project T21 will help us, submit information for NHS funding. So this is something which is possible in the future. So let's talk a little bit about the endocannabinoid system, the one which was discovered in 1990, and that sort of changed everything. So what is it? What does it do? It's a homeostatic regulator of the physiological functions of the body. So all humans, all animals, vertebrates, invertebrates, we all have the endocannabinoid system. It exists, we just didn't know about it. It's a neuromodulatory system. The main function is to maintain homeostasis of the body in response to the environment. So it enables the individual to have a neuromodulatory effect in response to the surroundings. And how does it do that? It's made up of 3 things. You have endogenous cannabinoids, things like you have endorphins. So you have endogenous cannabinoids. These then act on the cannabinoid receptors, and then once it has acted, they are broken down by enzymes and degraded. And now that we understand this system, or have started to, we are able to use its effect for therapeutic purposes. These are the two main endogenous cannabinoids, anandamide and 2-AG. Anand is a Sanskrit word which means joy and bliss. So it just refers to the effects which are produced by these endocannabinoids. So as we can see with this slide, it works pretty much all over the body. It has widespread functions, which is why it is extremely difficult to study as well. So on the brain, learning, memory, cognition, reward and addiction, appetite, anxiety, depression, skeletal muscles, nociception, bronchodilation. Oh, there are multiple functions. So we talked about these two endocannabinoids. They then act on the cannabinoid receptors. So what are these receptors? They are 2G protein coupled receptors, CB1 and CB2. So the CB1 receptors are present mainly in the brain regions and also less in the rest of the body. So you can see the green ones are the CB1, and we can see they're mainly in the brain, but also in the rest of the body. The other receptors are the CB2. They have a more, so where are they found? They're mainly in the immune cells. Immune system being mainly within the gut, and that's where you have it. And you have it all over the body as well. So, and they're most abundant in the brain, and the most densely populated areas where they are hippocampus, amygdala, hypothalamus, and frontal cortex. Now, we're all familiar with these areas, and it is very interesting that because this is the density, these are the areas which are responsible for mood enhancing effects. They determine our emotions, the behavior, pain, how we feel about things. So the area determines the effect what we're going to have. And if you were to take one thing away from today's slide, I think it would be this point. Extremely important, and I found this really interesting, that CB1 receptors are almost absent. They are either sparse or absent from brainstem, medulla, and thalamus. What do we have in these areas? You have the respiratory center. So unlike opiates, which will act on all this brain area, but they will also act on the respiratory center, leading to respiratory depression, which is why we know we prescribe opiates, and you're constantly looking, is the person going to stop breathing? And that's what leads to the mortality and the life-threatening effects. These receptors are not very sparse or not present. So these, even if the dose of the cannabinoids was high, you would not experience the life-threatening effects as you would with opiates. The CB2 receptor, the other one, is a peripheral receptor, and that has a very important role in pain modulation, immune function, and inflammation. So which is why when you activate the endocannabinoid system, you generate an anti-nociceptive response in situations of inflammatory hyperalgesia and neuropathic pain. So this is how you can utilize the cannabis endocannabinoid system to produce things like for improvement in hyperalgesia and pain and inflammation. So recap of that would be, so you have endocannabinoids acting on the receptors, and once they have acted on the receptors, they get broken down by these enzymes. The cannabinoids don't hang around all the time. When there is a demand, so when the homeostasis is required, they are synthesized, and they're also very quickly broken down by these enzymes. So because of which the long-term side effects are not that much. So this was a very exciting discovery, and it was then thought that the medicinal value of cannabis is so that we can modulate this endocannabinoid system by the use of phytocannabinoids, which are plant-derived cannabinoids. So that's where you get them from the cannabis plant. So about 400 of them are known, out of which 100 have been studied and are pharmacologically active. But the two most important ones are THC and CBD, which is probably the ones which you may have heard of. So what is THC? So it is the psychoactive component of the cannabis. The way it works is it's a weak partial agonist on the CB1 and CB2, binds similar to anandamide. So that is why it is sought by the recreational users, because it causes a high. But it also has well-known effects. It improves pain, it improves appetite, digestion, emotions, thought processes. So there are a lot of effects which it would have. CBD is a negative allosteric modulator of CB1, but it also acts on a number of other receptors. And the effects it produces are analgesic, anti-inflammatory, anti-anxiety, and antipsychotic. This is the non-intoxicating one. So you people, and you may have seen, so Holland and Barrett, for example, would be selling CBD. This is the non-psychoactive one. The previous one, THC, this is the psychoactive component. But they have different uses. So, for example, CBD can be used for seizures, convulsions, antipsychotic effects, neuroprotective. So our colleagues in psychiatry, for example, they tend to favor the CBD oils more. THC is more effective for muscle spasm, improving sleep, appetite, pain, nausea, vomiting. So in pain clinic, we tend to use a combination of those more than pure CBD. But this is why in the clinics we work as a multidisciplinary team. So there would be pain consultants, we'd have some neurologists, some psychiatrists, and nurses. So that would be our team. So let's have a look. So let's see how they actually work in chronic pain. Now, CB1 and CB2 receptors are located at some key sites, and they are involved in the relaying and processing of the noxious inputs. And they do that by decreasing signaling in pain pathways. So we are all aware that you have the pain pathway, which goes from the periphery to the brain. And the way we studied it was that levels of endocannabinoids are elevated at the key sites in the area where the pain processing happens. So if you look at the pain pathway like that, which is what we're all familiar with, so the opiates would act at, say, that level. Your non-steroidals would work at the tissue injury levels. So the way the phytocannabinoids would be through CB1 and CB2 receptors. They will act on the central nervous system and decrease the concentration of the excitatory neurotransmitter glutamate, which is what a lot of other painkillers do as well. And they cause a decrease in excitability. They also reduce the pain signals which are going, and they also reduce the inflammation of the pro-inflammatory substances from the mast cells. So they work throughout the pain pathway, and they have very wide-ranging effects. So that sounds interesting. So within the clinic, we started to use opiates. Now, obviously, cannabinoids are not the first line. When the patient does get referred to us, we will have tried all the medications. We would have tried we had gone through the MDT. They've had physiotherapy, psychology, injections. They would have had all of that. And then we are even thinking of cannabinoids. So by the time the patient reaches that level, a lot of them may already be on opiates. So what we find is when we started using cannabinoids in such patients, what we found was that the patients started using less of the opiates, which we found really interesting, and overall led to an improvement in their quality of life. And why does that happen? That happens because the cannabinoid receptors and mu receptors occupy same areas of the pain. They both work. They cause analgesia through a G protein coupled mechanism. They may also increase the release of endogenous opioids, so you don't need so much of the external opiates. And so not only are in the same brain area, however, because they are less in the medulla and the respiratory center, they are not as lethal as the opiates. So an increased dose will not make a patient stop breathing. So that was quite a landmark study, which is at the bottom, in which case, where they said that patients used less and less opiates once we started them on cannabis. This was another study from European Journal of Internal Medicine. Another very important group of patients who come to pain clinic are the elderly. You see, and we really were very interested to see that can we actually use this cannabis in them. And this was a study on 2,700 patients with a mean age of, say, 74 plus minus 7. And there was a marked improvement in their condition. Pain level was reduced, and about 18% of them stopped using their opioid analgesics or reduced their dose. Another very important thing is you don't want the elderly to have falls. And again, using opiates and stronger medication, that can happen. Use of cannabis led to less falls than it did with stronger medications. Obviously, sorry, we have to undergo a very slow titration because orthostatic hypotension can happen. So the slow titration really does help with that. So how do we actually use it? Let's have a very quick look at that. So the patient presents to the GP with symptoms. The GP would then refer to a doctor on the specialist register. So the patient will first come to pain clinic. They don't normally go straight to a cannabis clinic. So they come to the pain clinic. We will then go through all our normal stuff. So they would probably we'll go along the WHO pathway, the MDT, injections, all of that would have been tried. But if the patient does not respond to any of that, then at that point, we may consider medical cannabis. Let's look at the formulation. So what does it look like? So if the patient does go for it, what does it look like? So it could be in the form, there are two main use forms. One would be oils and another would be cannabis dried flower. So the patient will get cannabis, so they'll get it through their dedicated pharmacies. We have dedicated FB10 forms, the pink ones, which we then send to these dedicated pharmacies. They will then send the oil to the patient, which will be a 50 ml bottle with a graduated syringe. We give them a titration regime, and they will then put a drop under the tongue, and then they titrate it up. Another method to have it would be dried flower, which is then inhaled via vaporizing device. UK guidance says that it should not be smoked, and it's not cost effective also, and it has a lot of side effects because the because the products can lead to problems. So medical cannabis is a very individualized therapy. There are no standard doses for patients. So so if we talk about the oil, we have a range of oils. So starting from only CBD to more THC and low CBD. So when the patient comes, they come to, we'll see either, as I said, neurologist, psychiatrist, or pain consultant. We will then decide, we will take the patient to the MDT. We will decide which particular medication would be of benefit. And then they will have appointments with us every month for the first 3 months, by which time we get them settled on a regime. And then they have longer appointments. So the general approach to using medical cannabis is go low, start slow. We titrate up, and usually they have titrated to the medication we want them to in about roughly 3 months. And that's what a guide looks like. So whatever medication they get, they'll get a guide that day 1, take this much, day 2, that sort of thing. Let's look at this graph. So if we look at this graph, this is for ingested cannabis. So the oil under the tongue. It takes about an hour to get into the system, but then it will stay in the bloodstream for about 8 hours. So gives a more sustained relief, and this is the preferred one for us in the pain clinic. However, so think of it like MST, but then the patient, on top of that, chances are they may have breakthrough pain. If they happen, they can then, for breakthrough pain, they can use inhaled cannabis, the flower to vape. That acts almost instantly, but then it comes down instantly as well. So most people will end up after the first couple of months on a combination of the two, but our preferred one being the oil. Adverse effects are early, and they are usually transient. Drowsiness, dizziness, fatigue, dry mouth. So these are the main ones we've seen. So there are a few cautions. When would I not use cannabis? Obviously, as I said, it's never the first line choice. It is always, we go through all our pain clinic things, and then if somebody has not responded, then we may consider cannabis. Unstable cardiac conditions, I would be extremely cautious in the use of medical cannabis. It can cause dose-dependent tachycardia and peripheral vasodilation, particularly high THC concentration, and that can trigger an MI or stroke in a high-risk individual. So I would be extremely cautious. On the other hand, people who have stable angina, they've been on the same medications for a long period of time, it's not a problem. But unstable angina, I would be extremely cautious. I wouldn't really prescribe to adolescents because they have, in research from street cannabis has shown that some neurodevelopment impairments can happen with chronic THC. So I would not prescribe it to adolescents. I think they should be managed by other methods other than cannabis. Respiratory side effects. Smoking is the one which would cause respiratory problems, but it isn't legal anyways. The products are mutagenic, carcinogenic, they can affect asthma or COPD. So we would not recommend that anyways for medicinal use. Vaporization, the products are heated to a lower temperature. So the toxic byproducts aren't so bad, and that causes less respiratory risk. Oral, if they were only to have the oil, like I discussed, then there would be no particular, it would not affect their breathing. It is contraindicated in psychosis, unstable cardiac conditions, if patients were hypersensitive to it, or if pregnant or breastfeeding. It is also known to be, CBD and THC act as enzyme inhibitors of cytochrome P450. So drugs which are CYP inducers or inhibitors, I'd be cautious with them. If a person is on warfarin, they will need regular weekly monitoring of INR for the first few months while they settle. Now, this is another slide which I was really, really interested in. And that's because when I first heard about medical cannabis, my concern was dependence. Why should I prescribe a highly addictive medication to my patients? I don't want to. But if you actually look at the evidence of dependence, it's only above caffeine. It is less than alcohol. So if cannabis is 8.5, alcohol is 22.7. After which comes cocaine, and then nicotine, and then morphine and heroin. So, and why do we just take it on this word? The reason I take it simply I don't take it only on space value is, now, you see, because it is not legal. So even if we prescribe it legally, patients cannot just put it in their bag and take it across to different countries when they travel. So the patients tell me that they will just stop the cannabis, even if they've been on it for a long time, they will stop it. They will travel out, come back in a week, 10 days, restart it. And when I actually asked them, I said, well, didn't you have any problems? You just stopped it suddenly. And they said, well, you miss it. It's like if you were habitual to have a glass or two of wine every day, you would certainly miss it, but you would not have the withdrawal. For example, if you were on morphine, you couldn't really suddenly stop the morphine for a week and then come back and restart it. Neither could you do that with gabapentin. But with medicinally, properly prescribed cannabis, people do it all the time. What about driving? So it's the DVLA says that it's the responsibility of all drivers. And if they think that they may be impaired, they mustn't drive. This is common to whether you start them on opiates or gabapentin. And so just to summarize, so cannabis-based medicines are now legal. They are a Schedule II controlled drug. They have a good safety profile. They are well tolerated. Addiction potential, yes, they are addictive medications, but you are then comparing them to much other medications which are also highly addictive but may have more side effects. So it needs to be properly managed. Current UK data shows that there's an improvement in quality of life for patients with chronic health conditions. And we are already collecting a lot of data regarding it, and hopefully which will become more available to us in the coming years. So you may be seeing a fair amount of it in the future. But again, if so I would sort of reserve it for somebody who's on long-term pain management, has been through the pain clinics, been through various specialties, nothing is working, they're getting side effects to medications. Then it may be worthwhile referring to a pain consultant who can then see that if it is suitable or not. So, and yeah, that's it. So thank you so much for listening.
Thank you very much to all of our speakers this evening. Right, I looked at the questions in the chat box, and it's looks like our consultants have answered. Let me just have a quick look. So the 2 prolactins, what is the right one? And at what points prolactin should we refer? I think you've answered this. Let me see, everything's okay. Here we go. There's one question for Dr. Guy. Do you think medicinal cannabis will be prescribed in primary care in due course?
To be very honest, I don't think that that's going to happen in the near future. I think it eventually will, but I think we're going to take many years for that. Even as I said, I think in total there must be about, when I first started, we were barely 20 people who were prescribing it in the whole country. As I said, we were speaking to people in Canada on MDTs to do it. Now there are about 70 to 80 people only. The evidence is being accumulated, but I don't think the use will be so widespread, because it is recommended that we go through anything else which the patient can have before. MDT management, chronic pain, most important thing is MDT management, lifestyle adjustments. I think they're extremely important, and cannabis comes way down the line, which is why it's for specialist prescription at the moment. Who knows what's going to happen in 5 years?
Okay, brilliant, thank you. And hang on, how much does it cost for a month on an average, for an average dose?
So I would say, so the patient, as I said, firstly, when they come in, they have an initial appointment, and the first 3 months, we will see them every month, because out of those 5 oils and the vape and this, that, we have to decide what they're going to settle on. I think the first month, it costs them around £300, but once they sort of settle on it, the average cost is between £200 and £300 a month.
Okay, thank you very much. Right, and I'm going to go back. Let's try and get this in order. Right. For migraine, for patients on SSRI, is there a safer triptan? More and more patients seem to be on SSR meds, and when co-prescribing triptan, and warning comes up, reference serotonin syndrome.
Thanks, Ange. So yeah, so many of my patients are on SSRIs and SNRIs. So it comes up all the time. To be honest with you, I have been a neurologist for a long while now, and I haven't seen a case of serotonin syndrome. And in terms of the literature as well, I don't think there are even case reports of someone suffering serotonin syndrome after they were given a triptan in combination with citalopram or whatever. I think it is a theoretical risk, yeah, and the warning will flash up on EMIS or whatever you're using. I just think they're both such debilitating conditions. If you discuss with the patient, discuss when we'd be worried about serotonin syndrome, copious sweating, palpitations, tachycardia, changes, they stop it there and they come to ED, and I'd explain to them it's vanishingly rare, and these are depression's important to treat, and migraines are important to treat too. Yeah.
Brilliant, thank you. Right, let's have a look. Okay, this is a question for Dr. Rahim. With the e-neura, is it possible it can make migraines worse initially before things improve?
It can definitely. I think the initial studies show that some of the patients dropped out of the studies because there was a worsening of the headache. I think it was something like 5 or 6%, because actually the benefit of the neuromodulation avenue is that they're much more tolerable than some of the potions that we have to prescribe to patients. But it could make things worse. I would just be super cautious if a patient has sort of shelled out to have e-neura, that they give it a good trial, because it could be, you know, migraine's cyclical. It might have been getting a bit worse anyway, and they're trying the machine, and, you know, it appears that the migraine's worse, and they've spent all this money. So whilst it's bearable to keep on going for a while, at least 3 months, because that's what the major, the big studies in the neuromodulation, that's the time frame they look out. But it could certainly make things a bit worse. Not permanently, though.
Okay, brilliant. Thank you. Thank you so much. So here we go. How does candesartan prevent migraine? Is this a class effect or restricted to candesartan? Have I said that right?
Yeah, no, you're saying it beautifully. So candesartan is a class effect. Losartan also appears to have anti-migraine properties, but candesartan is the one of the class that we have the most evidence for, and it's the one I'm most familiar with. And I think it's slightly better tolerated at, you know, the 32 milligrams, the big dose, than losartan is, in my albeit limited experience with managing hypertension. In terms of how it does work, very long story, but migraine's a neurovascular sort of issue where you have interplay between dilation of the cranial blood vessels and triggering of sensory pathways. And we think the way it works is by increasing the threshold you need for that triggering process to happen. So raising the threshold for a migraine to start.
Brilliant, thank you. So, right, so for Dr. Guy, do you think it would be safe to prescribe medical cannabis for a person in a safety critical job like a train driver?
Yeah, very good question. Again, this isn't much different from us prescribing morphine or gabapentin or something like that. All of these drugs have potential for impairment. There is no safe answer. So yes, it is not that a train driver cannot have cannabis. What we would recommend is that firstly, when we titrate it up, we go low, start low, go slow. And not only that, they have to take it, we strongly suggest that they only take it at the time. They have to take time off work so that they can get settled on it. They cannot just take it and go driving their train the next day. That is not recommended at all. They must take it when they have some time off. If they feel impaired, they cannot drive. And these are all discussions which we would have with patients, whether they were to have morphine or gabapentin or anything like that, most certainly with cannabis. The DVLA, if you read the DVLA website, what it's going to say is that the onus at the end of the day will remain on the patient, whether or not they're impaired. What we recommend to patients mostly is that if a patient is in a critical job like this, I would say take it at night. It lasts 8 hours, even the oil. Do not take it in the morning, and if you can manage like that, or they have to work it out. And that's what the appointments are for, to discuss these things with them. It's not that it cannot be prescribed, but we have to be cautious because there is potential for impairment.
Brilliant, thank you. Have I missed any questions?
And Jana, there was a question about prolactin, which I left for the question time to answer intentionally.
Sure.
So I think the question was from Mohammed. So if prolactin is mildly raised, how should we deal with it to request macroprolactin levels? So I wouldn't get too lost on macroprolactinemia. It's very rare for a raised prolactin to be due to macroprolactin. So macroprolactin is a form of prolactin which we don't think is biologically active. And very rarely it can be the cause of a raised prolactin. So if your patient comes back with raised prolactin levels, it depends on the level. So if it is mildly raised, you need to take a drug history. Certain medication like antipsychotics can raise prolactin. If it is because of a pituitary problem, you can have a prolactin that is raised because of a tumor that is pushing on the stalk. So that's called stalk effect, but that's usually less than 1,000. And we say even prolactin up to 3,000 can be from stalk effect. If it's a prolactinoma, then the prolactin levels tend to be in the thousands. And so a raised prolactin then should make you look at the rest of the pituitary profile and ask the patients for symptoms of hyperprolactinemia. Are their cycles regular? Do they have galactorrhea? And then that should prompt you to either refer to endocrinology or to get an MRI head first and then refer if needed. All right.
Brilliant, thank you. Oh, here we go. Let's have a look. Some patients buy CBD oil from health stores and from abroad, and they want GPs to prescribe them. Do you advise GPs to oblige?
No. Because we live in the UK. You see, in the UK, sorry, can you hear me? Yeah.
Yeah.
So in the UK, we have to prescribe with the MHRA guidance. If you have to prescribe within the, I think it is very important to prescribe within the legal framework. The legal framework says it is legal for a person on a specialist register as long as it is this, and this. Yes, CBD is available from health shops. We do not know what the concentration of that CBD is. We do not know, it clearly does not have any THC, which is the part which is going to help with their pain in the first place. It's available from the health shop. It's over the counter. If they want to buy it, they are most welcome to do so. MHRA does not say that. MHRA says that it should be by somebody who is able to diagnose the problem, offer alternatives, and then give the correct strength. So we have so I don't think GPs would need to do that. They are quite safe in telling the patients, if you want to buy it, if you want to buy street cannabis, that's up to you. If you want to buy not something which we would recommend in the least. Similarly, if CBD is available, we do not know what it is. If you still want to try it, that is up to you. I don't think GPs need to feel any pressure that they have to prescribe it just because a patient is getting from a health shop, and hence, and it is effective for them. I don't think, because that is not within the legal framework of our country.
Okay, brilliant, thank you. I cannot see any more questions in here, but there's a lot of, I have to echo what a lot of our GPs have written in the chat box about. First of all, thank you very much to all of our consultants for some very interesting and informative talks this evening. So really appreciate you taking your time out for these educational sessions for the GPs. So thank you. And also thank you very much to our GPs for joining this evening. If you do have any questions or would like to refer any of your patients to our consultants or any of our HCA services, please do reach out. And I think we are coming up to 8 o'clock, so we'll close the meeting and say goodbye to everybody. So all the best.
Thank you so much for having me.